Welcome everyone. Thank you for joining NeuroTalks this afternoon. Today we have a very special guest. He is Professor Jonathan Coutinho. He is a stroke neurology at Amsterdam University Medical Center, has achieved his PhD under the topic of cerebral venous thrombosis, and has been leading several stroke-related research projects. We all know that cerebral venous thrombosis is a very rare cause of stroke, and medical management with anticoagulation has been the standard therapy for its treatment. Also, endovascular treatment has also been used in selected cases with different devices and results. Today, Professor Coutinho is going to talk about his recently published paper on JAMA Neurology on the effect of endovascular treatment with medical management and versus standard care on severe cerebral venous thrombosis. This in the context of the 2-act trial. So Professor Coutinho, thank you so much for joining this project, and welcome to join to NeuroTalks.
Thank you for that introduction. Yeah, so it's a great honor to present some of the data on of the 2-act trial. It was also presented at the European Stroke Conference already 2 years ago when we didn't have all the follow-up data available. So it took a while to collect all the data and publish the final publication. But I'll start with some basic background information on CVT because as mentioned, it's a quite rare disease. So it's always good to provide a little bit of background before we dive into endovascular treatment. And I'm looking forward to having a discussion what the position should be of endovascular treatment of cerebral venous thrombosis. So as mentioned, I'm a stroke neurologist, so I'm not an interventionalist myself. I was the lead PI for the 2-act trial, and we have a very close collaboration with our neurointerventionalists here. And there's also historically a very strong collaboration with Portugal, with Professor José Ferro from Lisbon, with whom I've been collaborating with on cerebral venous thrombosis for probably almost a decade now. So we always have a close collaboration. Okay, so let's start. So yeah, so my disclosures, I was in the steering committee of the Respect CVT trial, which was sponsored by Boehringer, which is on the Bigotrend for CVT, so it's not really related, but still CVT. And of course, I was one of the PIs of the 2-act trial, which in a way is also a disclosure if you're going to talk about that same trial. Okay, so if you look at CVT, a little bit about the epidemiology, it's of course a very rare disease. It's not as rare as we used to think, but still the incidence is about 12 to 15 per million per year. And it's really a disease of the young. And when I talk about that, I often show this graph where I've plotted the relative incidences of arterial stroke in purple and of CVT in blue. So these are relative incidences per age group, and where you can see obviously that ischemic stroke mostly affects people of 75 years or older. CVT, more than 2/3 of all patients are younger than 44. And in fact, the median age is around 37 if you look at the large series. And the other thing from an epidemiological point of view that always stands out is that these are mostly women. 75% are women if you look at adults. And the reason is the gender-specific risk factors, especially the use of oral contraceptives and pregnancy-related cases. So if you look at the clinical manifestations of CVT, these are, again, data that come from the ICVT, which José Ferro was the head and is still the largest prospective study on CVT. Of course, most of these patients have a headache, around 90%, and then focal deficits, they affect like between 20 to 40% of cases. Seizures are very common in the acute phase, which really makes it stand out compared to other types of stroke. So 40% in the acute phase. And in the very severe cases, usually the ones with thrombosis of the deep venous system or with large parenchymal lesions, patients sometimes are comatose at admission, but that's only 1 in 20. So if you look at the parenchymal lesions that you can see in these patients, it's mostly intracerebral hemorrhages and cerebral edema. And usually those two go hand in hand. So here I show you two common parenchymal lesions that you see in these cases. On the right, you see what would be typically called a hemorrhagic venous infarct, although that's technically not a very good term. But this is a characteristic lesion that you see in CVT. So it's a larger area of edema in which there are patches of hemorrhage. And it's called venous infarct out of, well, I guess it's historically, that's what we call it. But most of this edema is in fact vasogenic and often reversible. So it's not really good to term it venous infarct. On the left, you see a different kind of hemorrhage, which we called, we described that a couple of years back, which are small juxtacortical hemorrhages, and they can be single or multiple. And this is a very specific finding for especially thrombosis of the superior sagittal sinus. Okay, so before we get to a little bit more detailed information on EVT and on the 2ACT trial, I want to start off with a case from our own hospital from a couple of years back. So this was a male patient, 47, that came in. He had a 4-day history of headache, and by the time he came into the ER, he had a decreased consciousness. And we did the workup, and it was found that he had a thrombosis of the deep venous system with bilateral edema, as you can see here, in the thalami and the basal ganglia, mostly on the left, but also on the right. Now, I won't go into details as to why, but it was decided to go for mechanical thrombectomy, which was technically successful. And then we follow up this patient, and if you jump all the way to the last follow-up at 12 months, this patient had completely recovered. There were no neurological deficits. So from this, you could say, we cured the patient, we did the EVT, and it was very successful technically, and the patient did very well. So given the severity of the condition of the patient in the acute phase, you would be, it would be somehow logical to conclude that the good outcome is the result of your treatment, right? I think that's a logical conclusion. But I think the problem with CVT is that these patients do well without EVT for the most part. And that makes it so difficult in this disease to determine if your treatment really adds something to that good prognosis. So again, if you look at the ICVT study and you look at the last follow-up, you see that around 80% of patients have an excellent outcome, which means they recover without any disability. That doesn't mean they're completely the same as they were before the CVT. They often have certain symptoms and complaints, but they don't have any disability, which would be how that patient I just presented ranked. And it's good to realize that a large proportion of these patients were in a pretty severe conditions in the acute phase. So despite the fact that they can be in a severe condition in the acute phase, if you treat them with heparin, in the long run, a lot of these patients will do quite well. And if you look at mortality, it's also gone down considerably over the years. While series in the 60s, they often reported mortality rates of 40 to 50%. Nowadays, it's much lower. It's usually between 5 and 10%. And this probably also relates to better diagnostic availabilities, which has resulted in the identification of less severe cases. So if you PubMed endovascular treatment for CVT, you get a lot of these kinds of series. So this is a paper that I noticed when I was presenting on EVT a few years back, and it's still relevant, I think. So this is a single center, large retrospective single center series, 152 cases of CVT, and they report on all kinds of outcomes, but they also report on endovascular treatment. And there's something in that abstract that grabbed my attention. They say all patients received systemic anticoagulation, and then they go on by saying 49% required endovascular treatment. And that kind of made me wonder, do these patients ever require EVT? And I'm not sure that the answer is yes, but let's go through that. If you look at what the guidelines say, the American Heart Guidelines says that you could consider endovascular treatment if a patient deteriorates despite anticoagulation. Now, the American Heart Guidelines are already almost 10 years old and really due for an update, but this is the most recent guideline that we have from the US. Now, the ESO guideline is a lot more recent, although it's also due for an update, I think. And there, I was a member of that guideline committee. There we say we cannot provide a recommendation on thrombolysis or endovascular treatment because of lack of evidence, but we suggest not using it in patients who have a low risk of poor outcome. Now, if you look at publications for EVT for CVT, and this is a PubMed search I did a while back, but the results will probably be still the same, except that the numbers have gone up. So pre-2ACT, before the publication of our trial, There were quite a couple of hundred publications on endovascular treatment, but there were no randomized trials, which is, I think, the issue, especially if we go back to what I said earlier, is that a lot of these patients do well without any endovascular treatment, which makes it so difficult to determine what the effect is of your added treatment. So these are some old data also before the 2-act, but it's still relevant because it led to why we started doing the 2-act trial. So if you look at, again, the ICVT data, you see that in that cohort, 14% had a poor outcome, meaning they were disabled or they had died at follow-up. And if you compare that to the outcome that was reported in these case series, just like the one I reported, if you put them all together, you see a similar proportion of patients with bad outcome. But then if you look at the condition these patients were in, obviously the ones with endovascular treatment were in a much worse outcome. So you could say, well, they were worse when they went into the endovascular treatment, but they had the same outcome. So that make you suggest endovascular treatment might be beneficial. But of course, there's so much risk of bias in these case series that really the only good conclusion is that there's insufficient evidence about efficacy and safety. Well, what about safety? I mean, there are some data out there, especially systematic reviews that looked at this before the 2-act again. And you can see is that the risk of intracranial hemorrhage is not negligible. So even in these biased series, the report is between 10 to 17%, which is quite high. But then again, we must immediately say, we don't know if these were symptomatic hemorrhages, it's often not reported. And we don't even know if it's related to the EVT. So it's a high proportion, but really we don't know if it's due to the CVT and how relevant these are. And the other complication, which I think is one of the most feared complications, is a perforation of the sinus or the cortical vein. Now, again, I'm not a interventionalist, but my interventionalists in this hospital have always told me is that it's really a different procedure trying to recanalize the venous system. And one of the issues is that for the large part, you go in blind, and that makes it more difficult, and that there's certainly a risk of perforation. It's not reported in the literature, which makes me conclude that it's probably underreported. So based on all these data, a lot of experts on CVT for a long time have been saying in one way or the other, we need a trial. That's basically what people have been saying. And a few years back, that's what we decided to do. And we called it the 2-act trial, thrombolysis or anticoagulation for cerebral venous thrombosis. It was non-industry funded. It was only funded by the Dutch Heart Foundation, so a non-profit organization. Obviously, industry does not really have an interest in these kinds of studies, right? There's no money to be made, so we never were able to have industry support this. But the Dutch Heart Foundation was able to support it with a small grant, but we were able to run the trial with that. So what are the design of the 2-act trial? And as Baptista mentioned, it's published in JAMA Neurology earlier this year. It was an investigator-initiated trial. And we selected severe cases with CVT that had a high probability of poor outcome. They were then randomized between standard treatment or standard treatment with endovascular treatment on top of that. The primary endpoint was the ranking scale at 12 months. And originally, we wanted to recruit 164 patients, but the trial was terminated after the first interim analysis because of futility. So some more inclusion criteria. Obviously, it had to be a radiologically proven CVT, and this is how we defined a severe CVT. One of these 4 clinical characteristics or radiological characteristics had to be present, so just one. And the reason we chose these 4 is because in the ICVT, these were the disease-related factors that were associated with poor outcome. So we said, well, one of these variables present means this patient had a high risk of poor outcome, and those are the patients we want to randomize to see if EVT adds something for the prognosis of those patients. So as I already mentioned, there's a strong connection between the Netherlands and Portugal if it comes to CVT research, which was the same in this trial. So there were 3 hospitals in Portugal that randomized patients, 4 in the Netherlands. And there was one Chinese center that contributed quite a few patients. They joined slightly later, but they were very active. So in total, there were 8 centers that participated in this trial. 67 patients were randomized, 33 to EVT, 34 to standard care. One of the issues always with these kinds of studies is the risk of crossovers. That was not a huge issue. Luckily, 3 patients did not receive their treatment as allocated. 1 was randomized to EVT but did not receive EVT. And the reason was very simple. The patient was randomized, and by the time the procedure was going to start, she had recovered miraculously, and it was decided, well, she doesn't need EVT anymore. So we didn't do it. And there were 2 patients that were randomized to control, but they deteriorated in hours to days after randomization. And the treating physician said that decided that the patient required EVT despite the randomization. So 3 crossovers. Follow-up was almost complete for all patients, and all patients were included in the intention to treat analysis and the safety analysis. So a couple of baseline characteristics. You can see slightly older in the endovascular treatment group, and there were some baseline imbalances, but no huge ones. NIHSS was 12 on median in both groups, which is quite high for CVT, of course. A lot of patients with seizures, a substantial proportion of patients were comatose, and of course, many patients had an intracerebral hemorrhage, and also thrombosis of the deep venous system were overrepresented, but that's of course because those were one of the inclusion criteria for the trial. So I guess this is the most important graph of the talk, which is the primary endpoint. You can see there was no difference between the 2 groups. Here you can see EVT group, and this is the standard care group. And the proportion of patients with an excellent outcome at 12 months was 67% and 68% in both groups. So the relative risk ratio is pretty much 1. Here you see the separate categories in the modified ranking scale, although I urge you not to draw any conclusions from that, because of course the numbers per category become quite small, so that makes it very hard to really look at those separate ranking scale categories. Some secondary outcomes, the clinical endpoints you can see here, secondary clinical endpoints, basically there was no difference. I'll get to the safety endpoints in a minute, but for the clinical efficacy outcomes, there was no difference. The only thing we did see was over here, that there was an increased rate of complete recanalization of the superior sagittal sinus in the chronic phase, so between 6 to 12 months. So that was almost 80% in the endovascular treatment group and around 50% in the standard group. So that was the only difference. Safety endpoints is worth mentioning. Mortality, again, so these numbers are small, so don't look at the p-value. None of them are statistically significant except for 1. So mortality was numerically higher in the EVT group, 12 versus 3%. New symptomatic intracranial hemorrhage, which is of course the most feared complication, in fact was lower in the EVT group, quite surprisingly. Again, not statistically significant, but there wasn't a high risk of symptomatic intracranial hemorrhage, which would suggest that the EVT was fairly safe. Although we did see perforations in 3 patients, and interestingly, this did not lead to a symptomatic hemorrhage in these patients, and that was because the perforations all occurred in the early phase of the treatment, when the sinuses and the veins were still thrombosed. So in all cases, the procedure was aborted, so there was no symptomatic hemorrhage. But of course, it is it is a concern that we saw this in almost 10% of the patients. And then for reasons I have no explanation for, seizures were somehow more common in the standard group after randomization, so 30% versus 3%. So a couple of details. It was a very pragmatic trial, so we did not specify how the endovascular treatment should be done, which is something you can always discuss, but we decided for a pragmatic approach. So you can see 91% of patients underwent mechanical thrombectomy with various devices, and around 50% underwent chemical thrombolysis, so usually in combination with the both. And access was mostly through the jugular vein, but some patients it was through the femoral vein. So I'm going to get to the discussion and the conclusion of the study. One of the questions, of course, is why was endovascular treatment not beneficial in the 2-act trial? And I think I've listed 4 possible reasons, I think. One, obviously, is you could argue that the study was underpowered. And my answer to that will be is that sample size is always going to be an issue with a rare disease, especially since we're only recruiting a subgroup of patients. And so it's really hard to solve that problem. Then again, I guess one would argue against this simply being a problem of being underpowered is that there was absolutely no suggestion of an effect. The risk ratio for the primary endpoint was pretty much dead 1.0. So there was no hint of an effect. And although we cannot rule it out, I don't think this is the most likely explanation. Patient selection, that could certainly be an issue. These are again the selection criteria that we used in the trial. Of course, you may wonder if that's the correct way to select patients. In ischemic stroke, of course, we're moving more and more towards imaging-based selection. And perhaps that is the way to go for the venous diseases as well. It could be that CT perfusion or even dynamic MRI could be a much better way of selecting which patients could benefit from CVT. Now, there's not a lot of research on that topic yet, but personally, I think that would be a very interesting study to see, can we use these newer imaging techniques to predict outcome in these patients? And if so, is that the way to select patients for additional treatments like endovascular treatment? So the third possibility, I think, are technical reasons. Just as a reminder, we all know, now we all do endovascular treatment in ischemic stroke, but the first 3 randomized trials, which were all published in the New England Journal of Medicine, or the 3 major, there were other trials, of course, but the 3 major ones, they were all neutral. And we should not forget, again, that there's quite a difference between endovascular treatment of the venous and the arterial system. We also saw a higher rate of perforations than anticipated. So that could also relate to issues with the endovascular treatment per se, so the procedure. And perhaps we have done this trial too early, and we should wait until we have new and specific devices that are more suited for the venous system. That could certainly be a possibility. And the fourth possibility is that it's related to pathophysiology, which is also, I guess, the most somber explanation, which would mean that endovascular treatment is never going to work. Because it could be that, I mean, we cannot reach these cortical veins safely with endovascular techniques. And it could be that thrombosis in those veins, those smaller veins, are actually pivotal in the pathophysiology of venous infarcts and thus in the outcome of these patients. So even though we may be able to recanalize the major sinuses, that may simply not be enough to decrease the venous pressure and improve the outcome of these patients. So that brings me to the conclusions of the trial. Or of this talk. I think the conclusion of the 2-act trial should be that in that particular trial, endovascular treatment did not improve the functional outcome of patients with severe CVT. And at the very least, we should say that endovascular treatment should not be routinely applied in patients with CVT. Now, that doesn't mean is that we should never apply it, and it certainly doesn't mean we shouldn't research it anymore. But I do think that based on this trial, we can recommend that it should not be routinely applied to these patients. And these are all the people that I'd like to acknowledge, which have helped with this trial, but also with other studies on cerebral venous thrombosis in the past decade or so. And thank you for your attention.
Well, thank you so much for this very interesting talk and your the presentation of your results, of this trial. Of course, they challenge interventional neuroradiologists as far as we think always that if we open the vessel, whether it is an artery or a vein, it's okay, because what we need to do is open the vessel. Or we need to open or we need to close, but we definitely need to do something. And when results are against doing something from an endovascular perspective, we always think of what can we do better, because we are still convinced that we need to do something. So having said that, I would like to invite everyone to put your questions as well. But I'd like to ask you, you refer that you have done sub-analysis of the reperfusion in regard to the location of the thrombus. So if the thrombus was in the superior sagittal sinus or in the other deep venous system. But the clinical results of the global analysis are very similar for both arms. What my question is, have you done a sub-analysis regarding the location of the thrombosis? If we are talking about deep thrombosis or superficial thrombosis, have you done that sub-analysis? Do you think it's something that should be done? Or you think that we should face this disease as an entire disease and we don't need to go into the location of the thrombus?
I think it's definitely something that's worthwhile to look at. The issue with the trial is that the numbers become very, very small, right? So it's, I mean, we for instance, we looked at different subgroups from a clinical point of view also, but also in the thrombosis of the deep venous system. And the numbers are in the supplement. We added it in the supplemental data. And for instance, there seemed to be a better effect of EVT in comatose patients, but the numbers dwindle down to like a handful of cases. So I think we should be very careful in doing these sub-analysis. I mean, basically, I don't think you can draw any meaningful conclusions, but that doesn't mean that the question is very relevant. It could certainly be that the location of the thrombosis makes a huge difference in the success rate of this procedure. I mean, I'd like to know your ideas and also perhaps of others in the meeting. My impression has always been is that thrombosis of the deep venous system is more difficult to recanalize with endovascular techniques and may also be more dangerous. So that may be a group that may not be the best group, in my opinion, to do EVT on if you try it again.
Yes, well, I do agree. I mean, it's always, from a technical perspective, more difficult to arrive in the deep venous system, and also, and for that reason, it's more difficult to put there and to use a device. And that relates to another question that you have mentioned, that probably the devices that were being used some years ago are completely different from those that we have now. So I'm sure that there is room for continue doing this research, as you mentioned. For instance, you have mentioned that Angiojet was using as a kind of aspiration system, and now we have different devices that probably can go further into the venous system and probably have larger caliber and can aspirate more thrombus. But again, that doesn't mean that will change the disease, the course of the natural history of the disease. So what we need to prove is not that we are able to remove the thrombus, but that removal is useful for patients, and that's, I think, was the main goal of your trial. But when you have a patient, and it's always difficult to come from trials to specific patients, but we need to do that relation, because that's what the day-to-day life is. And when you have the patient going deteriorating from a clinical perspective, it's difficult to just don't do anything else, but you are just trying to say that you probably there is no benefit to do anything else. We don't know. I completely understood. But so from your perspective, what should be the future for this disease in regards to treatment? Shall we try to find better drugs, or shall we try to find better devices, or both of them?
I think there's a couple of remarks on that issue. I think sometimes we are confronted with these patients who deteriorate, and the first question is, why do they deteriorate? And there's a couple of possibilities. There could be seizures, which means you should treat that. It could be that they are at the point of herniation, right? I mean, you sometimes have edema with large hemorrhagic infarcts, and you have a risk of herniation, and the patient becomes comatose. So my suggestion would be certainly not to try EVT in those patients, because the issue with doing EVT, once you start recanalizing the sinuses in that phase, you put the patient under sedation, you recanalize the sinus, but that will not affect the point of herniation, because simply at that point, you're too late. So those patients, I think you should do a decompressive surgery because the outcome of that is, in the long run, is quite well. But that doesn't mean is that there's no place anymore for endovascular treatment. I think sometimes you do have a case that deteriorates despite everything we do, and you think that the increased venous pressure is really the issue there. And in those patients, I still think that you should consider endovascular treatment. And I mean, I'm in the committee of the ESO guideline, and we're going to have to discuss it, of course. But I think to some extent, that's also how we should phrase it. We should say, look, the 2ACT shows that routine application of endovascular treatment in these patients, that doesn't help. But that doesn't mean is that there's very select cases where you should consider it. And obviously, then the question is, which device should you use? Personally, I think, and that's something that we have learned, the angiojet is probably not the best device. So I think we should move away from that. But of course, it's very dependent on what the interventionalist has experience in. And the last thing I'll say about this is, again, the imaging modalities to select patients. I think we should study CT perfusion, dynamic MRI in these patients to see, does that predict which patients do worse? And can we use that to select patients for any additional treatment?
Okay, yeah. So yeah, I was just going to ask you about perfusion, and I'd like to, if I may, try to know something more that I guess you know about perfusion and cerebral venous thrombosis. So, do you have any kind of new knowledge on that? I mean, are you doing any research on that?
No, we haven't started a research project on it.
Okay.
It would certainly be of interest. I mean, we just finished a big study on the bigotrend for CVT, and we're going to start a big phase 4 study on DOACs for CVT. So we're tied up in quite a lot of research projects in CVT already. And this has been something that we've been thinking about. We haven't really formalized it, but it's certainly something I would be interested in doing. I'm not aware of any other similar study that's ongoing currently. I know the group from Lisbon, like Diana Souza Aguar, she's very interested in imaging modalities for CVT. So I haven't talked to her in a couple of months, but it could be something that she may be interested in putting together. I always say, if you want to research CVT, you need to go international. I don't think there's any point in doing these local single-center studies anymore. I think if you really want to do something, you have to find international collaboration. And if people are interested in doing this and having a good idea, I would certainly be willing to listen to it, because I think it's interesting.
Yeah, probably MRI has some role, like we are now studying the vessel imaging on MRI. Probably we can study the sinus as well, but yeah, I'm just talking about that. But definitely something that we should think about. Dr. Jani is asking how to differentiate between patient cohort thrombectomy or the compressive craniectomy based on imaging and symptoms. So, well, thrombectomy probably not. Compressive craniectomy, you were talking about that, suggesting that if there is need, if there is herniation of the ankles or of the
so the craniectomy patients, those are the patients that we see that they clinically deteriorate. So they either become comatose or with a pupil dilatation, things like that. And then when you do the imaging, you see large, usually unilateral parenchymal lesions with large mass effect. If you have that combination, then I would always recommend do craniectomy. We used to do EVT in these patients in the past, and we've published on that, and the outcome was horrible. By the time we stopped sedation and the sinuses were open and the patient was dead, that was basically the conclusion. So we stopped doing that, and we started sending them for craniectomy, and they have a much better outcome. So I think if you see that combination, you should go for craniectomy. Sometimes you have patients that become comatose because of diffuse swelling of the brain. We've seen that in a couple of cases. So there's no real large parenchymal lesions, but there's some sort of diffuse swelling, and these patients do very poorly. They become comatose, A-reactive pupils. We've done bilateral decompressive surgery in 2 of those cases, and the outcome was terrible. For some, and I don't know what happened there, but in both cases, by the time the surgeon did the craniectomy, the brain somehow exploded outwards. They had these massive swelling, and sometimes they couldn't even close the skin anymore. It was really quite horrible. So if they're comatose and you don't see a large parenchymal lesion that explains the coma, then I would be reluctant to do craniectomy. But if you have the large parenchymal lesion, the mass effect, and the clinical signs of herniation, then craniectomy is the way to go.
Yeah. Jonathan, thank you so much for your time. And also, I'd like to congratulate you for this excellent trial. That is definitely something that will be probably criticized. Many people will put many questions, and because is definitely something very, very challenging. Well, thank you for doing that. And I'm sure that there will be new studies coming from your team or from other teams in the way that we can select patients according to what the therapy will really benefit these patients. And I remember when we started doing thrombectomy, there were problems as well. And then we understood how to select patients, which patients should be treated or not. And that is fading slightly as well again. And now with cerebral venous thrombosis, definitely need some more specific guidelines in order to treat in the best way. So thank you for what you have been doing, and thank you for joining NeuroTalks. Just let me tell our audience that we are stopping for now for 2 months. I'm going on holidays, and so we will be back in September with new ideas. And thank you for joining NeuroTalks for these couple of months. It has been very successful. Thank you for the participants and for the audience. So it was a pleasure to do it for the last couple of months. And I will go back in September with new subjects, new topics to discuss in an independent way, which is, I think, very important. And again, Jonathan, thank you for being with us.
My pleasure. Thank you, Thiago.
Thank you. Bye-bye. See you in September.
See you.